And here to take our con position, we've got Dr. Biswajit Kar, arguing that revascularization is not superior to unloading first.
Thank you and good afternoon. Wow, what a data-full zone, and I'm debating something which is a data-free zone. But that was a great exposition, Sandeep. But you showed a lot of peer-reviewed publication. And what does peer-reviewed mean? It creates dogma when a lot of people get together, publish some things, and that becomes history. Why this is relevant? I want you all to see this picture very carefully. Sandeep in 20 years would probably look like this. But I take it with reverence. He's one of the most revered physicians. He's the first physician who started treatment of acute MI. And see what he said as the bottom line. The standard of care at that time, the consensus was absolute bed rest, the importance that can't be more clear. These are the three papers. First one showing that thrombosis causes acute myocardial infarction. But then the next 30 years, the treatment of acute MI was those two papers. Absolute bed rest, armchair treatment, and oxygen. And the greatest advance happened after 30 years when morphine and nitroglycerin came and camphor and caffeine came. And it took 40 years to treat the arrhythmia with quinidine and digitalis and the onset of coronary care units. This is the evolution of treatment of STEMI, as you can see. For 3 to 4 decades, the treatment was bed rest, oxygen, and morphine. And that was the state of the care at that time, the state of the art, as we say today. It took 1980s when the first thrombolytic therapy came, which made a huge difference. And then, in 1999, Cindy Grimes and Bill O'Neill is here, their paper showing that stents were beneficial based on Andreas Grundtvig's first PTCA and the paper. And this is the landmark paper on which the current treatment of AMI stands. And that's what Sandeep said. Revascularization is the best thing to do. This was in 1998. We have gone 30 years without making any difference in myocardial infarction. We've celebrated this as our treatment and current therapy. And this is the evolution in a nutshell. You can see it took 3 to 4 decades to make any difference in mortality in MI. So for all the spectacular achievements that's been said, there's always a very ugly backside to the story. You got to understand. This is what is missed. If you see majority of the MI patients, only 771 out of 1,000 will die of the MI, but 5,871 will go into heart failure. So what we are doing is this curve. The black shows the decline in mortality for MI, but the red shows the increase in mortality with heart failure, because that's what we are trying to do. So we're just kicking the can down the road. People are living a few more years, but they're dying. And these are the sobering statistics. 25% of the first STEMI, the person who gets a STEMI for the first time, will be admitted with heart failure in 1 year. Every 30-minute delay in reperfusion increases the infarct size by 30% and mortality by 7.5%. And more importantly, for every 5% increase in the infarct size, 1 year heart failure increases by 20%. So what can we do to reduce the scar size? You can't keep opening arteries like revascularization and hope that this will get better. Hope is never a good strategy. And why should it matter? The economics. This slide was shown by Marvin Constam also. You can see the exponential rise of heart failure by 2030. This is the projection, both in men and women. And it should matter. The cost is more than 80 billion just managing heart failure. The total budget this year for Medicare was 823 billion. So 1/10 of it goes in only in heart failure that we are creating, and we say this is the state-of-the-art treatment. Here, somebody says it's a tragedy. For me, that's an opportunity. And that's what I'm going to debate here for him. This is a case, like he showed a case, so I need to show a case too. This started many years ago. Remember the time? I will go to this. It was a roofer. There was a hurricane going in Houston. We are not new to that. 49 years old roofer. He had a stent. He went to a dentist, couldn't take Plavix for 5 days, and then he started having chest pain for 6 hours. And he was rushed to our hospital because all the other hospitals were waterlogged at the time. And when he reached it, he went into a VT storm. So we took him to the cath lab. This is not you can't see the tandem cannula. I'll show it to you. We spent about half an hour putting the tandem cannula. Those days we used to do blind transeptal, even doing CPR. So we did that, and when the first angiogram was showed, the stent was occluded 100%. It was full of clot. We did aspiration thrombectomy. And just to prove that I'm telling the truth, you can see the tandem cannula seeing here on the right upper side of that picture. So you'll expect 6 hours of chest pain, ST elevation, and with this kind of thrombus load, patient comes to you with a VTVF storm. We repeated a MRI after about 2 months. Show me the scar. There's a swivel of the scar at the apex of the heart, and you can see right at the apex that the white thing, but the wall motion is fine, except for the right at the apex in the anterior part, there's a little infarct. So that's the first time we said there is something to this. Door to balloon time is important, but this door to unload time must mean something. This, Dr. Fraser used to tell me, you learn a lot from your failures, but you should also learn from your successes. And this was the success. Something happened here that the patient did not have a massive MI despite having 6 hours of MI. So that was our crystal ball moment in 2003, because all the talk about unload started after 2005. Then there was a proliferation of a lot of devices, but they're not made equal, as you have seen that. It's only the middle part that you unload the heart. In others, you either increase the afterload or you make no difference, like a balloon pump and ECMO. Why does it matter? This is an animal where if you reperfuse only after LED occlusion, you see the pressure volume curve shoves to the right. And on the bottom side, if you unload the heart and then revascularize, it moves to the left. Why is that important? Because of this. The stroke work of the heart reduces to almost nothing, and most importantly, the oxygen consumption goes down to almost zero if you unload the heart. Why is that important? Remember, it's the supply-demand. Your supply is cut off with the MI. How do you reduce the demand? Bed rest was fantastic. Armchair treatment was good. Morphine was better. But unloading is even better than that, because now the oxygen requirement of the ventricle is less than zero. And this Wampler, long ago, coined this word called functional reperfusion. That means the decrease in myocardial oxygen demand, the increased supply of microcirculation and collaterals, and decreased damage by the reperfusion injury adds to decrease in scar and infarct size. And this has been shown in LV stroke work, direct correlation with the infarct size. The first is, you can see between the two curves, the transvalvular pulse is the black one in the middle, is the smallest scar, both in terms of total LV mass and also the area at risk. Then the preclinical study started. These are the 4 groups. Remember the groups, group 1, 2, 3, 4. 1 is reperfusion alone. Second is only 15 minutes of unloading. Third is 30 minutes of unloading pre-perfusion. And fourth is unloading after reperfusion. And look at this. The top one in the MRI shows the scar. The red part is the area was at risk, and blue is the Evans blue, which is the perfect myocardium. Look at the unloading. All the unloading was done in 30 minutes. The scar size was much smaller in the 4 groups. Even though the reperfusion, which was a complete reperfusion, an animal with a normal coronary arteries, where you open the LED completely, can't be better than that, your scar was still bigger. And this is a heat map of all the genes which is expressed because of infarct. And if you see, the first column is sham, second is primary reperfusion, and third is primary unloading. The unloading looks much similar to the sham, but in the primary reperfusion, it just reverses completely, because all those genes find expression because of severe hypoxia, and all the elements of tricyclic, the Krebs cycle, the tricyclic acid cycle, all are upregulated with unloading, but downregulated by reperfusion because the electron transport chain and the mitochondria are severely damaged. Here you can see the structural integrity of the mitochondria and the electron microscopy at the bottom. The middle portion, anyone of you who are not conversant with reading electron microscopy, you can see that those mitochondria look different than the first and the third, which is sham and the unloaded. And all the other elements of the electron transport chain, you can see there is a complete differential in expression of those genes. And this explains the thing. If you take injury and the first is normal, the both very functionally efficient fatty acid oxidation and the aerobic glycolysis, which happens, is supporting the Krebs cycle, which is supporting the mitochondrial integrity, and there's no injury. But between unloading and reperfusion, you can see which is bigger. The complex 1 gets damaged with injury, but with unloading, it is preserved. That is the number 3. And if you use ECMO, where you increase the afterload, it gets even worse. So unloading is clearly doing something. It is improving the substrate utilization. It is protecting the myocardium, and protecting further reperfusion injury. And the that also affects apoptosis. Both parts of apoptosis, the left side curve shows the anti-apoptotic gene on the right side, which is the B-cell lymphoma and the B-cell lymphoma XL, which is anti-apoptotic. On the left side, you can see the markers which show apoptosis, which is the caspase 3. Just the reversal. That means the apoptosis goes down if you unload the heart, but if you reperfuse the heart, the apoptosis goes up. Same thing, DNA fragmentation. You see the tunnel sequence. If you see on the left side, the topmost is sham, the middle is group 1, which is reperfusion alone, and 3 is reperfusion but unloading before that. So the DNA fragmentation is also less. And all the elements translates into clinical being. The BNP, which is the adverse remodeling that happens eventually leads to heart failure, the BNP levels in the infarct tissue goes down, in blood it goes down. So as a result, 28 days later when you do the MRI, you see the scar. Depending on the apoptosis, the scar is less, the apoptosis is less, and the infarct size is less. This is the MRI, not very different to my patient's MRI. If you see only primary reperfusion, there's a huge anterior MI. Primary unloading, there's no anterior MI. So to unify all these things, what happens is, as you unload the heart, you promote the stromal growth factor, which is a very important anti-apoptotic mechanism, which goes along with the CCL4. Once they bind, it starts the risk kinases. Risk kinases is the reperfusion injury salvage kinases. Those get activated, and once they get activated, the pro-apoptotic signals get suppressed, anti-apoptotic signals get better, and the mitochondrial integrity improves. As a result, the cell survival happens. On the other side, if with reperfusion, these things goes on the negative side. You cause more damage. This is the first clinical evidence, 2024, hot off the press from the Japanese registry. Out of 3,000 patients, 700 patients had an acute MI, and those who were unloaded more than 30 minutes ago, more than 6 hours, had a clear survival advantage. And this can explain what happens is, if you see the first and the second curve, you can see the difference. One in red is the myocardial infarction. Blue is the amount you save by reperfusion. But if you unload, that blue is cut in half because that's the reperfusion injury. As a result, you save more myocardium, you decrease the amount of scar. So based on this, the STEMI DTU pilot study, it's not in shock, but the acute MI has challenged this current paradigm because one of the biggest barriers had been this door to balloon time, which has stopped any trials or any design of any trials to improve therapies, to improve the MI. And this first time, based on the pilot study, they could prove to FDA that the 30-minute unload time, like Sandeep said, every 10 minutes count, he's right. But when you unload after that, that 30-minute does not add to any adverse signals. There was no prohibitive signal seen. As a result, FDA allowed that trial to go forward. And I'm happy to announce STEMI DTU pivotal study is completed. We're waiting for the data to come out. I think next year sometime they'll present the data. I think we are all hanging our hats onto that. But that only shows that unloading and revascularization both are important. But unloading prepares the myocardium for reperfusion, and hence revascularization will benefit, but only after you unloaded the ventricle and not before that. Consensus that we can develop, as you can see, but for 300 years, people thought sun goes around the earth based on consensus. So we can't go by consensus. If you see meta-analysis that you showed all the studies, if you take meta-analysis of all the science put together, it shows that it is not significant on the forest plot. So science and statistics can only prove so much. So meanwhile, I think I'm willing to compromise, even if I don't agree with your position, but more importantly, we'll collaborate so the best of us can carry the others in this debate. Thank you.
All right. Thank you. All right. We got a little bit of time for discussion. This is a really important topic. And why don't we start with Steve and let the panelists make some comments. We have about 6 or 7 minutes to go. Go ahead, Steve.
So I don't think I'm going to solve this dilemma in the next 30 seconds, but I would like to point out something. I mean, I think that some of this is very local and has a lot to do with local expertise, and I think we saw that. So Sandeep showed us a case with a DK crush technique with very sophisticated revascularization. Dr. Carr showed us a technique with the tandem heart put in up front, and so I think that the point of, I think that we're talking about time, and whatever we do, the idea that we can do it quickly with the resources that we have is going to be a key component to success.
In the ECLS cardiogenic shock trial, patients with the acute MI-related cardiogenic shock were randomized into early ECMO plus reperfusion versus reperfusion alone. And the ECMO was placed at the time when the reperfusion was occurring, before or during the time, in the cath lab. So your door-to-balloon time and door-to-reperfusion time were equal. The trial delivered neutral results. There was no mortality benefit. So can it be interpreted that early unloading really does not create extra benefit? Or does it mean that reperfusion by itself creates enough hemodynamic benefit? Reperfusion was successful in 98-something% of cases that they actually don't need unloading anymore.
I think a quick point I'd like to emphasize, Sandeep mentioned this earlier, but danger was not meant to understand if CP before or after revascularization was key. It was just emphasizing that if you're still in a state of shock, regardless of when the PCI was performed, the patient should be supported before they send them to ICU. So this is, I think, a message we want to remember is don't send them to the unit if they're still in shock despite revascularization, and say we'll deal with an Impella or whatever the pump may be later on. Is if the patient is still in shock, the patient is despite revascularization or is in morbid shock before revascularization, unloading should be considered before you send them back up to the unit.
I'm not a cardiologist, so I'm just a simple doctor for a small country with sometimes limited resources. And so I echo Steve Hollenberg's comments on the local aspect. And I think that one other thing to discuss is the fact which patient may perhaps benefit from the unloading, because of course, I guess that systematic unloading in all patients coming may perhaps be a little bit complicated, and especially on the financial aspects for a country. So I don't know what will occur with the tariffs on that, but maybe indeed some countries may not be able to afford this kind of major expenses if we have to unload every single patient.
So I'm from one of those countries in Canada where not all of our cath labs across the country even have Impella access. But I think that one of the things we have to be cognizant of is that unloading and support are not the same thing. Where we're getting much better at supporting people early when they're coming in shock, even before revascularization. But just as our two debaters just mentioned, is that one thing that interventional cardiologists love is the immediate gratification of seeing that vessel opened and that beautiful result. But what we don't see often as interventional cardiologists is that 25% readmission with heart failure in the months down the road, and the subsequent mortality that people have as their infarct size gets bigger, because that's handled by often different teams that those patients might not ever come to the cath lab again. And so I think understanding now that the paradigm is shifting not just from that immediate moment in the cath lab, but what can we do in the cath lab to help prevent those challenges down the road in the months to follow, that's where I think the next steps of our focus are going to be.
I just want to echo Dr. De Becker and Hollenberg that my fear is scalability, and I think it's scalability of technique and scalability of resources. That we've seen at our centers, at your centers, what Impella can do in the right hands. Microaxial flow is an incredible tool, but then is that generalizable as it reaches the lower volume operators that are out there? If we start putting this into every routine MI or every routine AMI-CS, I can see a lot more patients coming in with complications in our ICUs and limb complications that are going to be challenging to recover from long term. And I'm a huge believer in the Impella. Like the 5.5 in particular has totally changed the way we practice in heart failure CS. But I've got fears in this space in particular.
So I'm going to make a couple brief comments before I turn it over to Dr. Smalling, who was a proponent of unloading when I was a small boy. Anyway, first of all, I think that it's really important to understand that STEMI starts with good PCI. Revascularization is essential. Paper by the Danish group, it was just published in JACC last year, shows that mortality continues to drop with what we're doing. If you do pre-treatment with P2Y12 inhibitors, you get to the cath lab fast, you do it, you should have in-hospital mortality of under 4%. We have a Midwest STEMI Consortium, which is 4 large regional STEMI centers, all do very rapid to the cath lab, pre-treatment, and we looked at we have over 20,000 patients. We looked at 6,000 patients with first anterior infarcts within the first 5 hours. The entry criteria for door to unload. The in-hospital mortality is 1.6%. The 5-year mortality was 4.7%. The need for hospitalization at 5 years, these are anterior infarcts. The need for hospitalization at 5 years was under 10%. So start with a really good regional STEMI system that treats people quickly with adequate antiplatelet therapy. Now, what's happening in the United States is not that. We just published a paper in JAMA that shows the data from American Heart Association. Patients at non-PCI centers, only 17% are being treated in adequate time. So I think start by making your STEMI system good with your adequate antiplatelet therapy, and then for the patients that need cardiogenic shock, who have cardiogenic shock, there is a need. I'll let you finish for us there, Richard.
Okay. Well, as some of you know, we've done a lot of work in this for about 40 years. But there's 2 phases of cell death in acute MI. One is acute calcium overload, which occurs very early. And if you unload the heart within 60 minutes of onset of symptoms, you can prevent the calcium overload. The second phase is apoptosis. Unloading also inhibits apoptosis. But you don't see the benefit until about 60 days, 30 to 60 days post-MI. So you'll get a reduction in heart failure, death, and rehospitalization if you unload prior to reperfusion. So that's what we've got. But clearly, getting the artery open very early is probably the best way.